Hello people, in this video we want to cover this incomitant squint. In this heterotropia you have two types, that is concomitant or incomitant. Concomitant means they have some disease in the eye, okay, and because of that there is squint, okay. But in incomitant, which we are looking at in this video, incomitant, basically the nerve that is supplying the muscle gone, or the muscle itself has some fibrosis or something. Directly the muscle itself is affected here. What do we want to look at? We want to look at incomitant. So incomitant means you have those gazes, right? The gazes, the angles will be different in different gazes. The amount of deviation varies in different directions of gaze, okay. It's some A and V pattern, this is called as. So in this you have basically these people, because of the amount of deviation varying and all that, they'll have diplopia, vertigo, confusion, disorientation, etc. And here they will it can be, what and all can be the causes? Paralytic or restrictive, right? Paralytic means the nerve is problem, so you can actually move the eyeball. If you pull it and you can move the eyeball. So this is paralytic, where you can do a forced reduction, so you can pull the eyeball. Restrictive means the muscle is fibrosed, scarred or something, so you cannot, even if you pull the eyeball, it will not move. So forced reduction test will not work here, but here if you give force, it will work. So now let us get started with the details of this incomitant squint. So basically this is a type of what? This is a type of heterotropia, right? Heterotropia. This is a type of heterotropia or manifest squint, in which the amount of deviation varies in different directions of gaze. This includes the following conditions. What and all are there under this? Paralytic squint, A and V pattern heterotropia, and then you have restrictive squint, okay. So now let us look at paralytic strabismus. So under paralytic you have neurogenic, myogenic, neuromuscular junction issues. So the lesions may be neurogenic, myogenic, or at the level of neuromuscular junction. So basically this paralytic means it is the deviation which occurs from complete or incomplete paralysis, or of paralysis of what? Of one or more extraocular muscles. Here you can blame this third cranial nerve, etc. Third cranial nerve is which one, guys? Third one is oculomotor, and it is innervating the eye muscles and ciliary body. So it is helping in movement of eyeball. So this third cranial nerve comes from the midbrain. Where is the midbrain here? So where is the third oculomotor nerve? So this one is coming from the midbrain, okay. So a lot of other nerves also help in the movement, right, of the eye or extraocular muscle. But anyways, cranial nerve 3, you remember, it is supplying all these muscles, okay. Superior rectus, inferior oblique, medial rectus, all that is supplied by this oculomotor. So the causes can be congenital inflammations, neoplasms, vascular lesions, trauma, toxic lesions, demyelination, etc. So neurogenic, the textbook is blaming third cranial nerve. They are not blaming the others as of now. Okay, then coming to myogenic, again here what will be there? Congenital lesions, okay. Trauma, again. Inflammation, myopathies, bilateral ptosis, diplopia, so many other things, okay. They are blaming hearing loss. What is this? Other associated symptoms, okay. So there could be a lot of causes for the muscle also having problem. Then coming to neuromuscular junction, like myasthenia gravis, right? All these can affect the neuromuscular junction. So here what happens? They are saying that in paralytic squint, these people will have diplopia, okay. Diplopia is main symptom of paralytic squint. Because of this diplopia, they can have confusion, vertigo, etc. Okay, they'll have a lot of other problems. Also, these people, they may tilt their head to compensate. Here they are telling one thing: the visual acuity is fine. Okay, visual acuity is fine. Basically, here they were telling in ConComitant that the visual acuity won't be fine, because of which there is squint. But here the visual acuity is fine, but they have squint. So yes, these people will have no issue with what? Visual acuity. They will not have any issue with visual acuity. Here we are talking about what now? We are talking about paralytic, right? Currently we are here in the paralytic one, okay. Here there is some image on paralytic. Look at this. This guy has ptosis on the right, and when they have lifted it, This eye seems to be out and down. So this is third cranial nerve paralysis, ptosis and divergent squint. Okay. Here they're talking about some pathological sequel of extraocular muscle palsy. Here in this photo they're showing right lateral rectus muscle paralysis. So this right lateral is gone. Remember, they have put it right on the side and left on the side for some strange reason, and right lateral is paralyzed. So they are showing secondary palsy of the left lateral rectus, and this left medial rectus is overacting and the right medial rectus is contracting. Some pathological sequence. So paralysis of the right lateral rectus muscle, in paralysis of that, what occurs? The overaction of the left medial, contraction of the right medial, and inhibitional palsy of the left lateral rectus muscle. This is pathological sequel. Okay. Now in palsy, ocular palsy, under the itself, they have so many clinical varieties. You have isolated muscle palsy, that is some muscles are affected, right? One or two muscles, one muscle. Lateral rectus, they seem to be telling, and the superior oblique. Okay, these two are the most common muscles. Then if third cranial nerve itself goes off, what and all will happen? You saw that here. You saw that there will be ptosis, deviation out and down. Then ocular movements are restricted. That is the whole thing. Incomittant means ocular movements are restricted. In this case, all in third nerve palsy, it is restricted in all directions except outward. That's why it is outward here. Accommodation also is lost. Then there'll be crossed diplopia when you raise the eyelid. When you raise the eyelid here, there'll be crossed diplopia. Head posture may be changed. If pupillary area remains uncovered, whatever that is, okay, but head posture can change. Then they are saying double levator palsy, double elevator palsy, characterized by superior rectus and inferior oblique, like characterized by paresis of the superior rectus and the inferior oblique of the involved muscle. Okay, then there is something called as total ophthalmoplegia. Total ophthalmoplegia means all intraocular muscles, extraocular muscles, all gone. Okay, that is total. If external means all extraocular muscles are gone, like internal will still be working, like sphincter, dilator and all that. Okay, then there is something called as internuclear ophthalmoplegia. There is a lesion in the medial longitudinal fasciculus, MLF. Okay, what is that? Internuclear OPH ophthalmoplegia. Okay, all these are the clinical varieties of this paralytic. Okay, in this case of paralytic, what and all checks you will do? Basically, you have seen whenever it is heterotropia, you will check for Hirschberg test, that light corneal reflex. Then you'll do cover test. For tropia, it is cover test, isn't it? You have seen that all. This is that Hirschberg's corneal reflexes. You can see if it is esotropia, the eye will be inside, but the reflex is outside. Similarly, for hypertropia, the eye will be up, so the corneal reflex will be down. Okay. Then one more test was cover test. You cover the eye and then you observe the movement in the other eye. Okay. So basically, when you cover this eye, if this eye, left eye is moving out, that means it was inside before, so it is left esotropia, something like that. Okay. Cover test that was. Okay. Now you can check diplopia. So this is showing diplopia, how they are seeing two images, right? Diplopia chart for patient, they have shown one diplopia chart here. They are seeing double. Okay, this is one thing. You can look at the details. Then Hess screen chart they are showing. What is this Hess screen? Tells us about the paralyzed muscles and the pathological sequel of the paralysis. Some pathological sequel they seem to be focused a lot on. Field of binocular fixation you will check. Then you will do forced duction test. Here you can see in Incomittant, here small font forced duction test we have written. What is that? That is to differentiate between this paralytic restrictive. Forced duction test means basically you will pull the eyeball. You will hold the eyeball and you will pull it here and there. Okay. If it is moving, that means it is paralytic. The nerve is not supplying correctly. But if it does not move, even when you pull, it doesn't move, then it is restrictive. The muscle itself will be having problem. So that's forced duction test. Something like this. See, they are holding it and they are trying to move it. Okay. So it is performed to differentiate incomitant squint due to paralysis of extraocular muscle or that due to mechanical restriction of ocular movements. If FTT is positive, that is resistance is encountered during passive rotation, then this is mechanical restriction. That means if you are when you're doing this, if you are encountering resistance, that means there is mechanical restriction. Okay, that is positive. Whenever you duct, you cannot duct, that becomes a positive. Okay, guys, then there is paralytic versus non-paralytic, some table they have given. So let us understand this. Paralytic will be sudden because nerve is involved. Diplopia will be there. Okay, diplopia, they are blaming only paralytic squint. Okay, then ocular movements are limited. Then head posture, nausea, vertigo. These people have diplopia, nausea, vertigo, and secondary deviation is more than primary deviation, etc., etc. What about the non-paralytic? This will be slow in onset, diplopia will be absent, ocular movements will be full, then false projection is negative, head posture is normal, nausea, vertigo is absent, secondary deviation is equal to primary deviation. In old pathological cases, so this is, everything is fine in non-paralytic, is it? Guys, let us talk about paralytic. How will you treat it? You will treat the cause, conservative measures, wait for self-improvement. Then you treat the annoying diplopia. Diplopia you have to treat. Then chemodenervation of the contralateral muscle with Botox. Okay, they are trying to give Botox here. Then where will we write the treatment for this? Treatment we'll write here with green. What are they saying? Some Botox, the injection, and they treat the diplopia, treat the cause, treat the wait for self-improvement. Then they are treating the diplopia. They are giving Botox, chemodenervation of the contralateral muscle. Then surgical. Last we are talking about surgery. Surgical is the same, right? What we have seen. So recession, resection. Still, what is there? A and B pattern hypertropia is there and restrictive. All these are coming under incomitant only. Shall we look at in this video only or what? Let's see. So we are in incomitant, right? In that, we have to look at this A and B pattern heterotropia. So the term A or V pattern squint are labeled when the amount of deviation in squinting eye varies by more than 10 or more than 15, okay, respectively, between upward and downward gaze. That is what we are looking at. And in this, there is esotropia, exotropia, A and B esotropia, A and B exotropia, etc. Just remember, this is because of oblique muscle dysfunction, okay? And this is A and B pattern heterotropia refers to vertical incomitant horizontal strabismus. Okay, if you can understand it, very good. Then what is the treatment for this? Same thing, okay, that muscle, fix the muscle. So here is you will recession you will do, or you will do resection. So in incomitant we finished paralytic, we finished A and B pattern heterotropia. Last one is restrictive, positive. Restrictive what will happen? There will be positive forced deduction test, okay. So we saw that forced deduction test. In this, if you cannot move, there is restriction, that means it is positive. If there is restriction, you cannot move, then it is positive. Positive means restricted. So mechanical restriction will be there. There will be small ocular deviation in primary position in proportion to the limitation of movement. The causes are Duane's retraction syndrome, Brown's superior oblique tendon sheath syndrome, strabismus fixus. What is the strabismus fixus? This looks interesting. A rare condition characterized by bilateral fixation of eyes in convergent position due to fibrous tightening of medial recti. Oh my. Restrictive, or both the medial recti have become tight. Then you have dysthyroid ophthalmology. This is what? Some problem in the thyroid. Incarceration of extraocular muscle in blowout fracture of the orbit. Some fracture of the orbit. Okay, so we have finished, guys, incomitant. So in this restrictive, what will you give? Same type of solutions only, okay.